Can we
This
have
conference will now
stations?
be
Maybe nine.
recorded.
Maybe
Hmm?
nine stations. Nine stations here.
Okay,
Let's
sir. So you have type of this.
let's start. So the urogynecology, actually you can in the start a very high standard, very high marks here with the urogynecology. Okay.
Hmm.
All you have to do is just pay attention, read the questions carefully. To put it into the simple words, this is a subspecialty subject.
Hmm.
So you are expected to be able to take a detailed history, understand routine investigations, urodynamics, perform examination, reach a diagnosis, and manage urogynecological conditions. You can refer patients to the secondary care for surgery, but you will have to confirm your diagnosis by urodynamics. So the topics they can ask you, the stress urinary incontinence, urinary incontinence, mixed urinary incontinence, fistula, and remember why I
Hmm.
mentioned this point here. Most of your patients, they are going to have vesicovaginal fistula, but they can
Hmm.
have ureterovaginal fistula as well. Okay? Maybe somebody sustained a third degree perineal tear, or there was like buttonhole tear was there, which was neglected or developed later, like there was weakness, and later
Hmm.
it out-pocketed, so we had the problem. Like ureterovaginal, it can be vesicovaginal through the bladder and the vagina, or through the ureter and the vagina, depends that in which area the complication occurred. And then the way you are going to fix the problem is also going to be different. So patient can have multiple complaints at the same time. Okay, it's not essential that they'll be having just one complaint. So
Hmm.
postpartum voiding dysfunction can be there. Yeah, sorry.
Yes, I hear. I hear you. Hmm.
Okay. Postoperative care is important. Pelvic organ prolapse also falls here. And then post-vaginal hysterectomy ward prolapse. Then there is another interesting topic which everyone forgets. That is incontinence is there for the urine, but there can be incontinence of the feces also.
Hmm.
Okay. So, and that is the incidence is like 15%. So if they will ask you a question on it, don't be upset, okay? Everything is essentially the same. Only the muscle tone and the damage is in the posterior compartment. The rest of the things are going to be fine, okay? And
Hmm.
mostly just remember the risk factors are essentially the same as the as for the urogynecology. Nothing else. Aging is the basic problem, okay, in both conditions, and the incidence is as high as 15% in the elderly population. So, what aspects of the OB/GYN care they can be assessed? Applied clinical knowledge, information gathering, or history taking. Patient safety is checked or is tested on all stations.
Hmm.
Communication with colleagues and the communication with the patients and their families. And they some of this can be in the good environment, some of it can be in the bad environment. Then remember, we are going to talk about the spikes if you are breaking the bad news. So that what can they ask you to do? Take a detailed history. Once they tell you take a detailed history, you're going to ask her everything, because as the senior resident, your job is to take the history and reach a diagnosis. Do all the investigations. If they tell you to take a focused history, then you're going to focus on the main complaints of the patient. Okay.
Hmm.
Then similarly, for the management also, you're going to talk about the main complaint. Okay. The one big word will be quality of life of the patients who are having urinary and pelvic floor problems. Quality of life is very important. Think about a person who has to rush to the washroom like 20 times a day. So it is enough to
Hmm.
ruin anyone's life. It can be very
Hmm.
hard, especially for the people who are like praying so many times. Okay. So how you should be starting Osce station in urogynecology stations. So as usual, read the scenario carefully, make a plan, execute your plan, then involve the patient in decision making, offer PIL. And if your patient has already undergone certain investigations, then just run urodynamics on them, Why? Because you want to confirm the presumed assumed diagnosis. And then after confirming your diagnosis, you are going to refer your patient to the secondary care.
mm,
So how you are going to start? You will say that I'm Dr. Muhammad. I will confirm patient's full name and age. I will tell her that I understand that why she is here today because she has problem with her water birth. So is this true? She will say yes. So then you should say if there is a role player. So if you don't mind, I need to ask you a few questions, some of them, and I like to examine you later in the presence of a chaperone, and then I would run some tests, and then we will talk about your management options. Is this all okay with you? Show her the roadmap, okay? The site map, the roadmap, so that patient
mm,
will understand what she is getting into. That is one thing, okay? Then, as we do for all the cases, we are going to start with the history of the present illness. What happened? When? What is the duration of the complaints? It is very important because if the history is short, like 2 weeks, even 3 weeks, or a few days, it will go in the favor of the acute disease, like she has developed infection. But if the problem is chronic, then we will tell her, tell us more, because it means that something has been going on for quite some time. Okay, so in the urogynec, the patient will have a
mm,
delay of like a years, not days or months. Why? Because they will think that maybe they have taken more water, that's why they are producing more water. Then they will think that no, maybe this is, situation, this condition cannot be treated. So again, they are reluctant. Basically, they are very much reluctant to go and seek help. They and sometimes they don't. They have no time. Like they're working on the weekdays and on the weekends they can't find a doctor. Then how many times do you need to pee a day, in the day and night? Do you need to rush? Do you leak or do you wet yourself with efforts? Do you have difficulty passing urine? Have you ever seen any blood? Then tell me about your drinking habits, like how much coffee you are taking every day. What type of coffee you are taking? You need to ask about the type of coffee also, because if she is taking the Arabic coffee, it is not like the other coffees like big diuretic, okay? And because they are taking in like sips, 3 sips, so it is not going to have much effect. But if they are taking like black coffee and large servings, then it means that they are diuretics, and otherwise she is
mm,
also overloading her system. Is it affecting the way you live and the way you look at yourself? What is the effect on your sexual life? What has been done so far? Have you tried anything? Do you have any other associated bowel problems? Very important to ask, because if she's having the bowel problems, also straight away she has the pelvic floor problem because the sphincters are not working well. Remember, at the end of the day, we all have just tissues. Okay, we don't have any metallic objects. This is tissue. Okay, and then do you feel something coming down below? Because maybe both symptoms they are because of the prolapse. So after taking the history of the current condition, about the bladder, about the urinary function, then you need to ask her about the past history. In the past history, start with the gynecological history, LMP, any problems with the periods, smears. And if she is postmenopausal, when was the menopause? Did she receive HRT or she didn't? What was the effect? Has she tolerated it? And then has she ever been diagnosed with thinning of the area down below? Or is there any itching? Is there any mass? Something? And then has she applied any creams, anything? Because maybe she has tried some estrogen cream because maybe she had this vaginal atrophy. Also important to ask her, did she ever have did she ever has this? Did she ever have this one, any bleeds?
mm.
What will the bleeds tell you? Why are we asking her here?
I mean the bleeding for postmenopausal where there is risk of endometrial cancer, risk
That
of
is one of the
endometrial,
things.
yeah,
That is one of the things.
endometrial cancer, atrophy,
Atrophy,
the most.
yes. Yeah, that is the thing you need to ask her, okay? So if you're asking about the pelvic floor problems, she is having the urinary problems, then one can wonder, why are you asking about the bleeding? You are indirectly seeing what is the level of estrogens in her body. You know what does the
mm,
estrogen do? Estrogen is going to retain the water. It is going to cause thickening of the mucosa. And
mm,
if we look at the the urethra has got three layers, right? And the mucosa, like there is a thin lining, then there is the mucosa. Mucosa is the smoothing tissue which is supported by the estrogens. After that, we
mm,
have got the smooth muscle, and then we have got the external muscle. The smooth muscle that is under the effect of the autonomic nervous system. So the hormones, they're not going to affect this one. The skeletal one, yes, it will depend upon the tone of the muscles, and also it will depend on the neurological status of the patient. If the pudendal nerve is intact, then you know the root value is S2, 3, and 4. So basically, the pudendal nerve, if it is good, your patient is going to have everything fine. But if this is not working well, then your patient will have the problem. So don't forget to ask her about the bleeding episodes. Remember, most of these problems, not all of these problems, like two-thirds of the patients are going to be menopausal. Okay?
mm,
And like I said, the patients, they are usually hesitant in seeking help, so you can add another 5 years like that. Okay? So by the time a person is like 60 plus, she is also likely to have multiple problems like that. Okay. So you will need to ask about them as well. But going back to the gynec history, ask about everything, any episodes of bleeding, and then don't forget to ask about the fecal incontinence. That is equally important. Maybe she's
mm,
already having some neurological dysfunction. Maybe she has multiple sclerosis. Okay, if your patient is especially is younger, maybe this is multiple sclerosis. If your
mm,
patient is gravid, multiple pregnancies, and she is obese, obesity is one of the risk factors, as we know, she is very much likely to have diabetes. So diabetics, they are producing more and more urine. Okay, maybe she's taking some drugs. So we'll have to ask about all of these things. Okay, then
mm,
go to the obstetric history. Have you ever produced, have you ever given births? Okay. How many children you have? What were the types of deliveries? Remember, we are mistakenly saying that if she has undergone cesarean sections, then she is not likely to have the prolapse. This is not true. Cesarean section is going to give temporary protection up to cesarean section number 3. But here in our setup, our patient is undergoing multiple cesarean sections. Anyone having the fourth section is going to have the same risk of urogynecological complaints as anyone giving birth vaginally. Okay, and then
mm,
this protection will last just a decade, and after that the risk of the people giving women giving normal births and those undergoing cesarean sections, the risk is going to be equal. Then what were the birth weights? Okay, because why? Because whatever is the weight of the baby, 3 kgs or more, they're likely to damage the pelvic floor, because at the end
mm,
of the day this is just the tissue. Maybe it was not supported properly. And then remember that 80% of the injuries to the pelvic floor, they are not even diagnosed during the life of the woman, unless she will have this MRI for any purpose, and then we will see that she had occult. Occult means hidden injuries. Okay, some injuries were there which were never diagnosed, and she is exhibiting the symptoms. Then, after that, if it is appropriate for her age, if she is in the reproductive age group, then you need to ask her, any plans to add children to your family? Are you planning to have more children? Because by definition, the reproductive age group is between 16, and in some countries it is between 18 to 45 if you're following the ACOG guideline, which we are following. So it is 18 to 45.
mm,
So, is she having planning to have more children? Okay. Then, if she's already menopausal, then it doesn't make sense. Okay. If she's up to 45, you need to ask her, because some of the problems they can be associated with pregnancy. And if she is planning to have more children, then there is no point in fixing them because after giving birth, she is going to have the same issues. Any problems in the postpartum period? Important. Did she have any retention episodes? And then did she have any overflow episodes? Both of these things are important. In one, she is unable to initiate urination, and in another one, she is unable to hold her urine. Okay. So, as we will do the stations, we will know that what to do in such cases. Okay, then ask her about the medical history. Like we discussed in the previous session, you need to ask her, are you generally fit and well? Or I will ask the patient, is she generally fit and well? Or she sees her GP for any disorders. If she has the complaint, then I would like to ask her, what is the duration of the complaint? What is the When was is she diagnosed to have some problem? How it was solved? Who is caring for her condition? And is she on some meds? What type of meds she is on? And what is her response to the treatment? Is she feeling any better or has her condition worsened or what? Okay. Diabetes, you need to know that this is controlled or uncontrolled because hyperosmolar blood, it means she has too much sugars in her blood. So this is going to act as a diuretic. Okay, so she is passing more urine and the blood is becoming more and more heavier, thicker, more viscous, and the kidneys function will be totally destroyed. Hypertension, what drugs she is on. As a general rule, your younger patients, they can be on diuretics. Okay, and the
Okay.
older ones, they will be on multiple drugs. So you need to see, are the drugs safe or she's still taking some diuretics and they are aggravating the problems. Chest problems are undermined. Once someone is coughing, they are increasing their intra-abdominal pressure and then it is transmitted down below. And in urinary incontinence, the only problem is that the woman is transferring her abdominal pressure to the urethra directly, right? If she has good angulation, the anatomy is normal, then the increased abdominal pressure is not affecting the urethra in any possible way. But here you can think like the abdomen and the bladder and the urethra, they are just like in one column. Okay, this is just an example. So if the pressure is increasing in the upper part, it is transmitted to the lower part, and since there is no support of the muscles, so the things will go out. She's going to wet herself. Ask her, do you have any coughing? Do you have any asthma? Cough? For how long you are having it? And have you ever been for how long you are having it? Because if it is an acute episode, okay, it may have a little role. That's why, in the start of the consultation, you need to ask about the duration of the complaints. If it is COPD, like she is having bronchitis, she is asthmatic, she has emphysema, so she'll be on the long-term treatment. Okay. So these three diseases are relevant here. Give me the example of the fourth one. Neurological conditions, I asked you, I told you before, okay? In the younger patient,
Yeah.
think about multiple sclerosis. It is very common.
Multiple sclerosis. Okay. Evo.
In the
Sclerosis.
older patient, you will have to
Okay.
think about
Yeah.
dementia.
Yeah.
You will have to think about yeah, give me another example.
Dementia, history of fall down, history of
Yeah,
spinal injury. I think
yes,
history of
excellent.
history uncontrolled blood sugar, as you said before.
Yeah,
Um, history of what they call it, controlled blood sugar. It turned out with yes, it come with overactive bladder. What else? What else? This is for the old, I think, for me.
yes. Yeah, that's good. If you are able to remember that, that's wonderful. She can also have
Mm.
diabetic neuropathy, autonomic
Yes, this is what
neuropathy.
I mean.
Yes. Okay,
Mm.
that will be one thing. Then second thing is that diabetics, they can also have plaques of the, like the areas have been peeled off the white matter of the brain, like that. Okay.
Mm.
Hypertensive, they can have multiple infarcts. They don't even realize, and they had tiny infarcts. Some blood pressure ruptured, some blood vessel ruptured, so they developed dementia. Okay. Then
Mm.
constipation. Sometimes your patient will have nothing, but there is constipation. The what happens in the constipation is that as long
increase
as the patient is
increase
yeah,
the pressure, so they have more يعني
yeah.
شو اسمه relapse and symptoms and شو اسمه and symptom of electrocyl will be more prominent.
Actually, what happens that when there is stool in the body, the stool contains some water, right? And this water
Mm.
is essential because then only then one can pass it and it will move forward. But with passage of time, due to the process of osmosis, the water is taken off this fecal content, so it becomes hard and dry. And the patient sometimes they can't even pass it because
Mm.
they can develop anal fissure, which is a very, very painful condition. Okay, and sometimes simply this stool it will develop like a stump, and this stump is impinging on the rectum, and it is impinging on the urethra, so the patient
Mm.
can't pee and the patient can't pass stool. Okay, so very important during the examination to look for the stump because sometimes this is the only cause, so all we have to do is
Mm.
that we need to evacuate it. So when we are asking the patient what is your full name and what is your date of birth, so we are seeing that the patient is oriented to time, place, and person or not. Okay, that is important. So when you are asking them one question, you are assessing multiple things at the same time. Ask about the past surgical history. Maybe she developed some complaint and the time is of essence. Okay. If she has developed something immediately after the surgery or in the 2 weeks, then the symptoms are going to be different like that. Okay. If she has like sometimes they will ask you a question that the patient is just 3 days post vaginal hysterectomy and now she is leaking urine. So maybe this is not even the urine. Maybe this is the collected water that is in the vault and it is
Mm.
coming out, or maybe the ureter was injured in the start, but the moment you remove the catheter, what happened? Now it has become evident. So ask
Mm.
about the time, and time. What happened? When? How it started? Okay, if you ask me about the keyword in the urogynec, that is when. It is going when it started. It is going to solve so many things for you. And if she has undergone any treatment before for the prolapse, ask her what was done. Even if they inserted pastry for her, then you know that pastry will also impinge on the walls. It can cause erosions due to its pressure because maybe it was not of the normal size or maybe it was way
Mm.
too hard. And or the patient was very prone to develop ulcers, like the old person, diabetic person, or the one having poor nutritional status, so they can have this erosions. And the second thing would be they will have infections. Okay, and these two things can occur with any type of pastry because remember that at the pastries are foreign bodies and they can trigger a reaction. If any incontinence surgery was done in the past, you have to know about it. What was done? If the patient says that I don't remember the detail, ask her, do you have any notes? Okay, okay, give me your. If she doesn't have that, okay, tell me about your healthcare number. I will look it up for you. Okay, because now we are not going to repeat the same procedure. Now we need to do something different because there are specific guidelines.
Mm.
Family history is very important. Family history of cancers, family history of blood clots, family history, any disorders running in the family. Dementia can be like familial, Parkinson's can be familial. Okay, so we need to ask about all of these things. Social history: do you smoke? Do you take alcohol? And remember that alcohol is one thing. If they're taking like plenty of the sugary drinks, even they are going to cause diuresis. Any ever used any drugs? So what is your profession? What do you do for a living? Because maybe she is lifting weights, maybe she's standing for longer periods of time like that. Okay, if you have someone elderly, ask them about the support system at home. And if she's a younger person, ask her, so how is life? How has been your mood in the last 4 weeks? Allergies, very important. What is missing here? We didn't
quality of
ask her
life,
about. Yeah.
quality of life, vaccination, um, occupation,
Occupation is
uh,
here right in front of you.
mm,
Vaccines,
الvaccines,
and contraception.
what else?
Contraception we didn't ask about her.
Contraception, yes.
Contraception.
If she received
Yeah,
HRT or not.
yeah.
Okay.
So these are the things, okay? So after that, you will do the examination. Always start with the general physical examination. I will pay attention to the general appearance of the patient, that she is comfortable, seems healthy or not. What is her height to weight ratio? That is BMI. Then what are the vital signs? Examination of the chest. Again, because maybe she is asthmatic, she has some problems, and the fault lies in the chest, in the lungs, and we are treating the bladder. Abdomen, you will do the inspection in the presence of chaperone in the with the consent of the patient. Never touch your patient without her consent. This is assault and battery. With her permission, and don't forget to mention this during exam. With her consent, I will proceed to examination. First,
Mm.
I will look at her tummy from the side, then from above. I will look for the contour of the abdomen. I will look for any marks. I will look for any masses. And I will look for the color of the skin. Then, with her permission, I will palpate the abdomen from above downwards and from above downwards, from side to side, and then in the pelvic region. The examination, and I'll be looking for any masses like fibroids. If the mass is soft, it may be a distended bladder. Bladder can
Mm.
accumulate up to 3 liters, and if the bladder is palpable, it means that the bladder is above the pubis symphysis. In a normal person, it should not be reaching that point. But if you are able to feel the bladder, it means that patient has chronic retention of urine. Then after that,
Mm.
you know that you have to do certain things. You have to do the Sims in Sims position, Sims speculum. You're going to put the patient in the left lateral position and you will ask her to cup. Then you will see, is she leaking with the cup? Then you are going to do the inspection. You can do the inspection. You are looking for all potential defects in the pelvic floor muscles, and you will tell her, I will ask the patient to squeeze onto my fingers, and I can use different methods, different scores to assess the strength of the muscles. They will like the Oxford score. You can use the King's score, and I will use the International Society for Continence questionnaire to assess all potential defects in the pelvic floor. That is one thing. And when you are inspecting, then you're looking at the mucosa. If it is pale atrophied, it means that this is the problem here. And then, if you cannot demonstrate the leaking in the left lateral position, what will you do now?
I think I would put the patient on either standing position and let her
Mm-hmm.
cuff to see. After that, we let her
Mm-hmm.
sitting position with the speculum. We see if she's
Mm-hmm.
with the cuff and let her ask the patient to cuff to see if there's something leaking or not.
Okay. Ask the patient to step down, stand by the side of the bed, put one
Mm.
foot on the ground, and the second foot should be on the step, the ladder the patient is
Mm.
using to climb the bed, okay? And
Mm.
then ask her to cuff, because now because when the both legs are down, they are also compressing the urethra. But if the one
Mm.
leg is up and one is down, then she can do that. You can just rub your fingers together, or you can just run the water, or you can ask the patient to wash her hands and you can demonstrate it. Okay, that is one of the things.
Mm.
That is for the objective testing. So here again, you can also do what else you can do? Why do we
Uh,
put
B,
the needle swab? Why do we do this swab test?
Q-tip test.
Yeah, Q-tip test. Why do we do
Q-tip
that?
test for شو اسمه يوترال hyper motility,
Mobility.
right? Hyper
Yeah. So
motility.
what is the yeah?
More
Why?
than, I think it is more than 30 degree.
Yes, you should be sure of the confident of that.
Okay, طيب,
More
okay.
it rotates by more than 30 degrees, so it means that the
Mm.
patient has some incontinence. This urethral hypermobility is there. Okay, you have done the examination and you have done looked for
Still
the
by manual
back.
BR.
Okay, and you have looked for the posterior compartment also. The thing
Mm.
after that, what will you do? Start with the bladder diary. What is the bladder diary? The patient is just telling you that this is for the control of the things and the basic definitions. This is.
Mm.
You have seen it multiple times, right? So you don't have to worry
Yeah.
about it. So this is just the graphic record of the activity. It will have, if we also call it Eurolog, Eurograph, you can say Eurolog. What is the date, the time, how much fluid she took, and then how much urine she passed, and how many episodes of the accidental leaks or something like that. Okay, so the you will want to know about all of these things. Okay, so that is the Eurograph. So we will ask the patient to keep bladder diary for 3 days. And basically, this is frequency volume record if this is a structured discussion. And it will tell you about the pattern of the activity. And then after 3 days, you can pretty narrow down it to the stress urinary incontinence or urgent continence or mixed pattern. And we can move forward. Start with a simple basic test like the urine dipstick. And if it is positive, start the treatment.
Mm.
Okay. Here, this thing is tricky. Okay. If the and we can send it for the culture as well. If your patient is symptomatic, but the dipstick is still negative, but the clinical suspicion is high, start antibiotics. Okay. Send urine midstream urine culture should be sent, and we need to start the antibiotics. If your patient doesn't have symptoms, then wait for the results. Okay. And here you will say, I will tell her that how we will take the sample for the culture. She should work, clean the area with a, this tap water, pass a little urine, and then take the urine. That's why we call it midstream urine. Just pass out some urine, then take the urine, and then after that, evacuate the bladder fully. That is a midstream urine. That the sample you're going to take. Then you will say that I will do the ultrasound to look for the residual volume. Residual volume
Mm.
is for different age groups. Okay, if someone is like 60, she can have a residual volume of 100 ml. Okay, but up to 50 in the younger one, we will say that up to 50, 60 is okay, but 100 is a cutoff if your patient is 60, and if she is less than 60, it should be below less than 100. After that, like you have done everything, we are not talking about the management here. We are just talking about the workup. So the things have been fine, patient is improving, so of course he is going to continue with that.
Mm.
But if the things are not improving and you need to send the patient to the secondary care, then you can say that further results, or what you will say. If my patient is not improving, I will take interim history, and the further results that I would request, they depend upon the results of the presenting complaints and response to the initial management, right? Because one thing is not going to fit for work for everyone. You need to see what happened, what was the response, for how much she has been doing this thing, and after that we need to run the urodynamics, and we will send the patient to
Mm.
the higher center. World is moving towards the conservative management, lifestyle modification, reduction of weight if BMI is more than 30. Though then studies in the last 3 years they have shown that BMI has no effect, but I personally don't agree with it because most of the urinary problems you are going to see in the obese people. Stop smoking, reduce alcohol, caffeine, modified drinking. And remember, this smoking, like the shisha smokers, they are also smokers. That is not something different like that. Okay, they are taking tobacco, but in a different way. And modify the drinking habit. Then supervise pelvic floor physiotherapy so that we know that they are doing it correctly. Aim should be to do Kegel exercises also. They're the same thing. That she is getting 8 contractions 3 times a day. For how long you are going to continue it? You are going to continue it for 12 weeks. 70% patients are going to improve, and 70 to 84% patients are going to improve. So you can, after 12 weeks of physiotherapy, and if the patient is benefiting, we will tell her that she doesn't have to do anything else, just a little bit of improvement of the lifestyle and continue doing these physiotherapy, this exercise, and she's going to be fine. And if you are suspecting like she's having urgent continence, then you will tell her that I will counsel her about having planned voids, scheduled voids. Okay, you will tell her, you will ask her that how often she is passing urine. Like the patient will have typical history that she has to run to the washroom, and sometimes she wets herself even before reaching the bathroom. Okay, so you will tell her that how often do you have to run to the bathroom. She will say every hour. Then you can say, okay, from today, just reduce your intake of the fluids, and try to pass urine every 1.5 hours. So don't wait till you have the strong desire to pass the urine. Just have timed voids, or the timed voids means that she's putting the alarm that every 90 minutes she is going to pass urine, like that. Once she is able to hold her urine for 90 minutes, then you will tell her that now try to pass urine every 2 hours. So after 6 weeks of bladder retraining, 60% of the patients, they will tell you that there is a 70% reduction in the episodes of incontinence. So you can say that 60% of patients are going to report improvement, so they can continue it. Then
Mm.
they can be referred to the continence advisors, and if the initial therapy is not working, then we are going to give them meds. We can give them the meds according to the type of the incontinence they are having. If they are having the mixed symptoms, then the drug would be duloxetine. If she has stress incontinence, then again she can benefit from the um, duloxetine. Whenever you will mention any drug, tell them what is it for and what are the side effects. The duloxetine, the most significant side effect would be a nausea and vomiting, which is going to occur like in 1 in 4 patients, and they usually quit the drug. If the patient is having urgent continence, then she can have like a potpourri. There are so many different drugs that she can take like that. Okay.
Mm.
So the drugs, okay, you can say anticholinergic drugs. Usually they will not ask you about the name of the drugs, but even if they ask you, you know that it's not hard to remember. Let's go over them quickly. So your patient can take different drugs, don't have to remember. Anticholinergics can be given, don't try to remember any drugs like that. Oxybutylin is our number one choice, but if your patient is 80 or she's very frail, don't give it to her, okay? Whenever you will give her, if she cannot tolerate the oral one, give her the option of the transdermal. Give each drug for 4 weeks. If the patient is benefiting, well and good, she can continue taking the same drug. No benefit, we need to change the drug, give her the second drug, and she will also take the second drug independently. Not two drugs, she will take one medicine at a time. Okay, one drug for 4 weeks, benefited, well and good. Not benefited, change the drug, and you can do that on telephone as well. Okay. So you can give one of the drugs, oxybutynin can be given, mostly we are giving it in the immediate release form. Okay, not slow release, immediate release form. Patient cannot tolerate the side effects, give them the patch. Transdermal oxybutynin. No benefit, give them tolterodine. Tolterodine, we can give the long acting as well. Third option would be prospium chloride, derifenacin, solifenacin, okay, fesoterodine. Whenever, like I just mentioned, whenever you are giving her a drug, you have to tell her immediately what are the side effects. Luckily, all of these anticholinergic drugs have the same side effects: dry mouth, blurry vision, constipation, tachycardia, drowsiness, and dizziness. These are the first line drugs. So they didn't improve the condition of the patient, then you have the option to go to the second line drugs. Second line drugs. So all of these three are going to act on the M3 receptors. M3
Mm.
receptors are
Receptors.
because if the system works like that, that if there is parasympathetic stimulation, we will pass urine. If there is sympathetic stimulation, we will hold urine. That is the thing, okay? So this is
Mm.
not working, then there are beta receptors. So you are going to give them beta 3 receptor adrenoceptor agonist. That would be Becmediol.
Mirabegon?
Yeah,
Mirabegon, you mean?
mirabegron.
Oh,
Okay.
Mirabegon.
So mirabegron, who should not be getting mirabegron?
I think a patient with, I'm not sure, with the close
Hypertension.
angle hypertension, uncontrolled hypertension.
Write down, because these are tiny things, but they are going to cause problems. So to
Will
save
have
your time, just
problems.
write it down. We will not give it to someone who is already hypertensive. Don't give it to them.
Regardless of controlled uncontrolled, different from
And it's
anticholinergic.
just this is just 10 mg, 5 mg, or 10 mg tab. Okay, just once daily. So it is like extended release tablet. Tablet.
Mm.
Okay, it is approved by the FDA. Already like 10 years that people are using it. Okay. So the drugs, the patient didn't have any benefit. So she's going to the secondary care. So we are going to run the problem. We are going to run other tests on her. That will be urodynamics. We will talk about the urodynamics when we do the station. Okay, but it is easy
Mm.
to talk about them. I will just show all of these things to you in a minute. Meds. So if it is appropriate for her condition, you can give her the pessary. Pessary, you remember that pessary, the side effects can be ring, shelves, horn, anything can be there. All are equally effective. But whenever you will mention any object, anything, tell about the good things first. What is the benefit? What is the drawback? Pros and cons. Mention both of these things, because
Mm.
if you don't mention, then it means that you have given her half the information, which is not going to get you marks. Finally, surgery. So pessary, infection, erosion, fistula formation. Okay, infections are very important. So where you are giving pessary to anyone, tell them that they need to come back after 1 month, and if the things are fine, then she needs to come back after 6 months, because you once you have treated the patient, you can't abandon her. What do you think? So lifelong care. And you will say, I will teach the patient how to take it out, how to clean it, and how to reinsert it, and if she will have any problem, where to seek help. And as a backup, I will give her the patient information leaflet. Give patient information leaflet to everyone. You have got more than 1,000 leaflets in the OB-GYN in Arabic language, in the language she understands. Okay. So we did everything for the patient. Nothing worked for her. Finally, we are thinking about the surgery. If you are giving pessary or you are giving the bulking agents, if indicated, you will tell the patient, we are going to give you a glue-like substance around your water pipe, and we are going to use it for the time when we are waiting for the surgery. So after that, you are going to tell them that what will be done for them. So the urodynamics. Tell me about the indications of urodynamics. When do we do
Uh,
that?
okay, before I think okay, with unclear diagnosis, for example, when
Mm-hmm.
okay, in case of diagnosis of incontinence,
Mm-hmm.
before surgery, before hysterectomy to rule out occult cyst incontinence, or before prolapse surgery to rule out occult cyst incontinence. What
Mm-hmm.
else? What else?
Okay.
Um,
One simple line. Very
hmm?
simple. One simple line. I will run urodynamics to see the function of the bladder. Okay. And if you have done the simple urodynamics and they are not helpful, then you will say, then I will do urodynamics to look at the function of the bladder and urethra. Okay. Then they will ask you
Oh.
about the specific conditions. Then you can say many things to them. So we know that if we have to record, we need to take we want to assess that where is the fault. We need to have certain things. Like we should know what is the bladder pressure and what is the abdominal pressure. For the bladder pressure, you have seen the patients that we will insert Foley's catheter into through the urethra, and we will make sure that it is in the middle of the center of the bladder. It is not touching the walls. And the abdominal pressure, you can take that through the rectum. If the patient doesn't accept that it should be inserted in the rectum, then you are going to put that into the vagina. Equally good, okay? And then we
Mm.
are going to record the pressure. Patient will be sitting on a special seat, and then she will pass the urine, and we will have the observations. So if they give you any urograph, for the urodynamics, always pay attention to the things they are showing you, okay? Look at this one. This is showing the flow, which is 2 ml per second. Is it normal? No.
I think 15 ml per second should be.
Yeah, 15, but average is 25, okay? 25 ml per second. So
Mm.
2 ml, she has some voiding dysfunction, or maybe she has some obstruction from the external side, or from maybe something is into the vagina, or maybe she has something inside the bladder which is obstructing the flow, or maybe this detrusor pressure is very high. Then what is the detrusor pressure? what is the vesical pressure, what is the abdominal pressure, okay, and how much urine she has produced. In each urogram, you're going to see this is the filling phase and this is the micturating phase. Whenever they will show you that detrusor is contracting, they will write down DC, okay? And sometimes they can
Mm.
be mean, they will not show you, but you have to think about it yourself. Sometimes to confuse you, they will put all of these things on the right side. So if they're putting these things on the right side, if they're not mentioning, so actually they should be writing, okay? If they have not mentioned, still you can look at this thing, look at the numbers, okay? Look, follow the timeline. Here the thing started and here now the time is increasing. So this is the filling half and this is the voiding half.
Mm.
So, and whenever there is a leak, they have to write L, leak, leak, leak. Okay, they have to
Mm.
write it. So what do you see here? Can you interpret this for me? Look at this one. This is vesical pressure. This
Mm.
is abdominal pressure. So the abdominal pressure increased and then the intravesical pressure increased. So
Mm.
did you pass any urine here? Can you
No,
see? Because
nothing, nothing
nothing.
written, nothing. Yes, tut.
Okay. So let's see what is this. This is detrusor overactivity. Why we say so? Because the detrusor is contracting here in the filling stage. Here the detrusor is contracting. Okay, that's fine. Okay, it can occur because this is the voiding phase, but this one is the filling phase, so
Feeling
that
face. Mm.
contractions should not be there. Why? Because they are unprovoked. Okay,
Mm.
here the patient didn't have any coughing, anything. Okay, so the abdomen was silent, but the vesical pressure was high, and then why vesical pressure was high? Because the detrusor was contracting, so the detrusor is the main muscle in the wall of the bladder.
Mm.
So if it is contracting, then obviously the pressure into bladder it will rise. Interpret this one for me.
Okay, this is the flow. I think so. 2 millimeter per second.
Mm-hmm.
Okay. Okay. She has leak in the filling
Yeah,
phase.
yeah.
She has leak in the filling phase while with the detrusor of activity.
Hmm.
Yes, was abdominal pressure increase.
Okay.
Okay, I'm not
We-
seeing the trouser. I'm not sure, but I'm not seeing here the trouser of activity here actually.
This is
But
detrusor.
yeah, but I'm not
Detrusor
seeing
pressure.
activity. But since there's a leak, I would say the patient came complaining. I would say it is the trouser
Look at
overactive
this one.
bladder or by urodynamic trouser of activity.
Look
Could
at
be.
this one. This is the abdominal pressure. Can you see this P abdomen?
Okay. Mm, mm,
Abdominal pressure, like she had a cough.
mm.
So intravesical pressure increased and she had a leak. So stress incontinence. Okay.
Assessing. Mm.
And detrusor is silent. So this is not detrusor overactivity, right? Because
That's
our
why I was
detrusor,
confused. I was looking for that
yes,
one. This is
yeah,
different graph. Okay. Type, okay. That
let
one
me
is
tell you.
trouser of activity only. We call it.
Yes, and this
Mm.
is the voiding phase. Okay, look at this one. This even this voiding curve. This is not perfect, right? Kinking, up and down, up and down. So if you forget everything about the urograph, just remember if you see two spikes, think about detrusor overactivity. Okay,
Mm.
you see three spikes, think stress urinary incontinence. Okay, three stress incontinence. Two
Mm.
detrusor overactivity. You can remember it like this: DO, detrusor overactivity. Stress urinary incontinence has got three words, so this is stress urinary incontinence. These are the things. Okay, so since this is not like a theory course, so we are not going into the detail, but to show you just for having a good concept. Epithelium, mucosa, and this is the middle smooth muscle layer, and the outer one is the striated layer, like that. Okay, so if this in the postmenopausal, this mucosal layer will be thin, so already this urethra will be hypermobile. If nothing else is there, only because of the estrogen, your patient is going to have weaker things like that. What is the most common type of incontinence? Stress incontinence.
It is
Remember
got. Mm.
49%, but you will say 50%. Then the second most common would be mixed incontinence. And the least common is urge incontinence. What do you see here? This is the voiding curve. It should be like this,
Mm.
okay? Bell shaped. If your patient is getting like this, so this is she's having voiding dysfunction. Similarly, here your patient and always ask about the dribble. This patient is going to have a dribble. She will pass some urine, dribble. She will rest. Then again she will pass some urine. Most dribbling towards the more dribbling towards the end of urination. So that's why history is everything when we talk about the urodynamic incontinence like that. Okay. So these things are just the repetition. So I
Yeah.
think that now you have some concept about that. So as we will do the station, so I will bring it back again like that.
طيب اوكي طيب.
Definitions should be accurate. Just a quick review. Urinary incontinence is when you pass urine when you don't want to, when the patient doesn't want to pass urine. Stress incontinence, it will happen when the pelvic floor muscles that support the bladder, they are too weak to stop you urinating, especially during exercise or if you cough, laugh, or sneeze. Overactive bladder is when the bladder tells your body that it wants to empty before it is full. You will pass urine before your bladder is full, and when the bladder muscle starts squeezing to empty out urine more than the normal. If you're passing urine more frequently than the norm than before, then it means that you have some abnormality. Urgency, a sudden desire to pass urine, which you cannot defer, which you cannot control. Frequency, how many times passing urine more often than previously used to pass. Urge incontinence, you are leaking urine and you have a sense of urgency to pass it. By the way, how often does a normal person pass urine?
I think once per night, up to 3 times per day.
Uh,
In the morning. So in the morning, 3 in the morning, and one at night.
on average, you can say on average, one is voiding every 4 hours, okay? 6 times a day, every 4 hours, okay? This is when the patient, when a person is taking like 8 glasses of water, okay? But and usually at night, if she is in her 50s, she should get up once. If she is in her 60s, she should get up twice to pee. If she is 70, then she can get up 3 times at night like that. Okay. These are silly things, but we have to know about that. So then important thing, know about the POQ curves.
Hmm.
Okay. So can you interpret this one for me? The points, 6 points, you should be focusing on the 6 points. Okay. Look at this one.
Okay, so AABB, it is for the sorry, AABA, it is for the anterior,
Okay.
BB and AB for the posterior, and yes, I know it, Doctor, I know it.
Okay, if it is A, it means it is near introitus. Okay, if it is
Hmm.
B, it is away from the introitus. Okay, C
Hmm.
stands for the cervix,
So
and D
cervix,
stands for the pouch of it,
cornets.
that is,
Hmm.
and the whole of this thing are diagonal. That is the total vaginal length, and they are not going to ask you to calculate the stuff for them. Okay, that is one thing. So then, key facts are that the lower urinary tract symptoms, they consist of numerous symptoms that can be categorized into the symptoms of the storage, voiding, and post-micturition symptoms. Lower urinary tract symptoms are most common and they affect, like, you round it up, like 40 to 60% of the population. Storage symptoms are the most common lower urinary tract symptoms. And prevalence of LUTs, it increases with age. Stress urinary incontinence is the most common form of urinary incontinence in overall. Mixed urinary incontinence and urge urinary incontinence, they are more prevalent in the elderly. Overactive bladder is a symptom complex which is presence of characterized by the presence of urgency, but it may include frequency, nocturia, and the urge leakage. This is the overactive bladder syndrome. Okay, get your definitions right if you want to get full marks like that. Okay, and then um, regarding these symptoms, if it is detrusor overactivity, the patient will have only urgency to pass urine, that she has to rush otherwise to the washroom to pee, otherwise she will wet herself. Okay. So then another question they want to ask you. What is overactive bladder syndrome? These are the symptoms. Pay attention to the word symptom complex. Okay, these are only the symptoms. What is recruiter overactivity? When the symptom of urgency, they have been documented on they have been confirmed on the urograph, then we call it urodynamic activity. We call it recruiter overactivity. So once your patient had symptoms of like she was having some problems, you have done the urograph, urodynamics, and now you have demonstrated overactive bladder, then we call it recruiter overactivity. What is urodynamic stress incontinence? Okay, when stress urinary incontinence has been confirmed on urodynamics, we call it urodynamic stress incontinence. These are the differences. Okay, overactive bladder symptoms confirmed on the urograph, on the urodynamics, that is recruiter overactivity. Stress urinary incontinence confirmed on the urodynamics, we call it urodynamic stress incontinence. Okay, so get your question, your definitions, everything right like that. Okay, so we can in the when we will do the mixed circuits, then I am going to show you more urographs. What is this?
Mm. This is cystogram.
Mm-hmm.
I'm not sure. Um,
Yeah, it's a
Cystogram, yeah.
cystogram. This is
Cystogram,
a
yeah.
big bladder
Big bladder, أيوه.
and retention of urine. Okay, look at the urethra. This is narrow. Okay,
Mm.
maybe there is some obstruction, something. So what problem can be here?
Could be urethral stricture, or I'm
Mm-hmm.
not sure. Is it urethral diverticulum?
Yeah, could
It
be
could be
diverticulum, but mostly it will go in the favor of the stricture or
stricture.
stenosis.
Stenosis.
Stricture stenosis has some external pressure because here we are not seeing all soft images nicely.
Could be
Could be some external
post
pressure.
operative,
Yeah, could
post
be something like
post link. طيب اوكي post
yeah.
tape. طيب اوكي.
Okay. Any questions? Any problem?
No, okay, thank you. Okay.
Okay. So let's go with the first case. So you will take 2 minutes and then you'll start.
طيب okay. Your patient is Mr. Ozan, 57 years old, office with involuntary loss of urine. So like what you like about ask about her complaint. What examination would you ask to this patient? Why? How do you examine the patient and you manage it? So, and once you think I would go with the all the history and
Take your time.
examination and
Take your time. Take your time. Organize your thoughts. Okay. And then we will start talking about it. I'm keeping your time.
طيب what you will ask about her complaint type. Okay. Um, طيب I'll start.
Okay.
Assalamu alaikum. I'm Dr. Muhammad. How are you? What's your complaint today? What's your age? Dr. Musa, what's your age? What's your occupation? Where are you? From where you are? What's your complaint today? You have loss of urine. Since when it started? How many since when it started? How many since how many months? What's increased? What decreased? Um, what decreased? Um, uh, does شو اسمه هذا؟ Do you have dysuria currently these days? Do you have increased frequency? Do you go to the bathroom increased frequency, increased nocturia? Do you have do you feel loss of your urine with coughing or with doing activities? Do you need to rush to the bathroom do you have urgency, or do you need to rush to the bathroom so that you can so not to pass the urine, or sometimes you can you hold yourself until to reach to the bathroom. um, um, what do you call it? Do you have any history of constipation? Do you have any history of diarrhea? طيب, do you need do you feel anything coming do you feel anything coming down there or not? um, what do you call it?
Okay.
This is it. Then
See,
I would go for past history quickly.
yeah, four
This
parts, so 2 minutes each. Sorry, Dr. Muhammad, sorry to
mm,
intercept. You have got four questions here, okay? So aim to
okay, okay.
spend 2 minutes on each of them, okay?
So I
So
need,
just to
okay,
get
so
this. So what examination you would like to do on this woman and why?
I would go for exactly initial university in culture,
Mm-hmm.
both with the urine. I would add either weight to cystogram. I would do urodynamic study if needed. I would go for CBC urinary culture, hemoglobin A1C if she's anemic or not. I would ask of this patient. I will examine the patient for a speculum examination, standing while standing and while in the bed to ask her to cough something coming out or not. I would do a bimanual examination. I would assess barbecue to see if I had any prolapse. I would do pedictum examination.
Mm-hmm.
Uh, I would do what they call perineal neurological test examination, and then I would do also Q-tip examination for mobility, mobility. Sorry, خلاص done.
No, you don't have to say sorry, no problem.
Mm.
Okay. So how will you do further assessment?
Based on my investigation, based on my finding, if the patient شو اسمه هذا this patient have very reduced urine. um, if it's come with coughing, I would do with the neurodynamic studies to assess the bladder and urethral function. Uh, mm, uh, the Q-tip will assess my management also as well. Uh, mm, I would do what you call for this patient. لا إله إلا الله. Um, um,
Start with general physical examination, height to
uh,
weight ratio, recent weight gain, changes, yeah.
I didn't do it for an examination type. Okay, I
Okay,
forget
and
about
after
it.
that, what is the first test that we do for on anyone? Look at this age. She is
Mm,
37. Is it possible
mm.
that she is pregnant and this is an unplanned pregnancy?
Yeah, yeah.
And since, yeah, okay, so the first test to run on her would be a urine pregnancy test, right? The second test would be to do the urinalysis, okay?
Mm.
That she has any, okay. So after that, what would you like to do? Ask her to write down a bladder diary, like the workup we talked
Yeah,
about.
I would ask them to do blood diary. Um, ليش blood diary
Like,
هذا? Maybe I will ask the questionnaire regarding her quality of life function. How is the effective life? Um,
I will
she's
teach
willing to.
my patient, I will give her a form, I will tell her how to fill this form
Mm,
and return to me in 3 days. After three
okay.
days, okay? And she should fill this form when she is working and when she is taking rest at home. Okay?
Mm,
So I would like to see the pattern that what is going on. That is the first thing you need to do, okay? And if she will
mm.
have the signs and symptoms of infection, then I like to start treatment for her. Okay, you can
Did
do
me
that.
for type. Okay.
First test in a younger woman of a reproductive age group would be to exclude pregnancy like that. Okay, these
type.
are the
Okay.
so let's say that she brings back her urolog and she is found to have stress urinary incontinence and her
Mhm.
BMI is 34. How you will like to manage her initially?
Okay, first I would go to ask the patient about lifestyle modification,
Mm-hmm.
such as reduce weight, reduce caffeine intake, reduce smoking and alcohol use, and increase and encourage her to exercise and do Kegel exercise, physiotherapy for 3 months at least, and um, what is what else?
Yeah. Go on. What else she can do? Modify the fluid intake, decrease the calcium.
Modify fluid intake to up to 1.5 to 2 liter per day. Exercise. I think this is it. Nothing missing. What I missed.
Yeah, that's
To review
plenty.
to review her medication. If she's taking a medication that increase her, well, that diuretic or diuretic that will increase her bas. This is from your line. Nothing else. Okay.
Behavioral therapy, fluid management, bladder training. If
Umbrella training.
if
Mm.
pelvic floor muscle training, she can do the if she cannot contract
Mm.
her pelvic floor muscles actively, then we can give her the biofeedback, okay? Because we will place a transducer on the perineal skin and we will ask her to contract Kegel. So you are giving her vaginal cones like that.
Mm.
That is one thing. So the functional electrical stimulation can be offered if she cannot contract the muscles, because in the younger patient you have to think about the multiple sclerosis also like that. Okay, we
Mm.
can give her anti-incontinence pessary,
The- This one
so
should
that
be
when
this one should be included from the initial management usually. All of these will.
no, later. Here, when you're talking about these things, just this is your answer.
Mm.
Okay. So the key is there in your detailed key is on your notes. I'm also writing down your score for all of these stations and I will send it to you. Okay, don't worry about
Mm.
it. You know, like in the first 3, 4 sessions, you should try to talk fluently. Okay, one
Mm.
thing should flow smoothly into another one. Okay, later I'm going to be strict about time limit and I would want you to say the specific things because the notes are already on your web page and you will not get the same stations. Okay, if you will,
Mm.
maybe you will find a similar station but it will not be like 100% this one, because I will show you something here. I've bought like these three Osce, circuits are here. Okay, but we are doing with
Mm.
another fourth one like that. Okay, so I don't know that which notes are available on your web page like that. So don't worry
طيب.
about it. Similar conditions, so you are going to do that. Then I didn't ask you that when will you follow her up. Tell her that she has to do all of these things for 12 weeks. If she develops a new complaint, she should come back to the clinic before her time. She should contact the person who is responsible for her overall care before that time. But if she's benefiting, then she should wait for 12 weeks and then she should come to us and for further assessment. So the initial management is just the lifestyle modification and the things. Okay. So we are not going,
Mm.
remember in the initial therapy, you are not offering her any drugs and you are
Mm.
not offering her any surgery or anything, just the advice. That is more than enough in the initial management. That is one. Take 2 minutes and then we are going to talk about that.
This patient is 52 years old. Woman developed 3 episodes of UTI in 1 year. Okay. Respond to antibiotics. Yes, antibiotic. Would you like to study? What complicated UTI was recurrent UTI? What is factor of recurrent UTI? طب I'm not prepared for this one بس خلاص I will go with it.
Whatever comes to your mind, never mind.
Yeah,
Just
حاضر حاضر.
so, what can you tell me about your patient?
My patient is a 22 years old lady. She has 3 episodes of TI in 1 year. Respond to treatment, so is not resistant. Um,
Mhm.
3 episodes in 1 year. Go with definition of UTI. Recurrent
Mhm.
UTI. Either way, it
Yeah.
is.
So, what will you like to ask her on the history? She's
First of
23,
all,
right? Yeah.
yes. First of all, I would ask her. I would ask her about her UTI when it's happened. Was it was it there's complete recovery between the period, or at least between the each attack another 2 weeks.
Mm-hmm.
how many other فيها؟ what did he have any culture or not before? Did she receive any medication? Was she is improved on it or not? And what kind of medication she received? Um, she has history of UTI before before this year, and she was seated. Now she came back again for her. Then I'll go for her past medical history. If she has any history of diabetic hypertension or شو اسمه هذا obesity before obesity, and or history of urinary retention, um, history of congenital anomalies, history of medical history. Um, this is medical history. Again, congenital history. I would see if she has any operation, any gynecological operation done, or any urology operation done before in the kidney or in the bladder or in the vagina, any history of stones. Um,
Mm-hmm. Okay.
I
So
think
when a
that's
patient comes to you with UTI, do you ask her that what has happened? The first symptom would be that increased frequency of micturition, like the increased frequency of passing urine. Okay. So
mm,
then what do you like to ask your patient? So does she have pain with it? Does she run a fever? Okay. Does she have pain in the tummy? Does she have pain in the back, in the renal angle? Okay. Has she passed any urine? And is she
mm,
having any other discharges from the passage, back passage? And then also, when very important to ask her, when was the last menstrual period? Okay, that is important. What is the relationship of these infections to the
mm,
period? Um, and you're right that if the patient has congenital abnormalities, she can present with the issues, but then she will not be presenting at the age of 23. Okay, the women who have like this urinary tract abnormalities, usually they will be diagnosed by the age of 3 years. Why? Because when we are removing the diaper and she's having the complaints, then obviously we are going to investigate her. That does she have an ectopic ureter or she has UTI or something like that. Okay. What was the circumstances? Very important to ask her: is she sexually active? Okay. Is she taking contraception?
mm,
Is there any possibility that she is pregnant? Does she have constipation? Because if she's constipated and she's training, then she can, because all of this area is under the control of the pudendal nerve. Okay, so maybe she's having some problems. Okay, that is a thing. And does she have pain on passing urine or something like that? Okay, these are the
mm,
here you're going to take a very focused history because see, you have got 6 questions. You are going to answer
mm,
them in 8 minutes. And remember, the examiner needs some time to ask you these questions as well. What is a complicated UTI? UTI with additional symptoms. If patient has anything in addition to increased frequency of urination, we will say that patient has a complicated UTI. What is the incidence of complicated UTI? 8 to 15%. Okay, it's not low, it's very high. If the patient has increased frequency of urine with several other associated symptoms like pain, fever, nausea, vomiting, loin pain, backache, hematuria. Okay, then we will say that the patient has a complicated UTI. What is recurrent UTI? Two episodes of UTI, two
in
episodes
six
of
months or
diagnosed, yeah, two
two, I
episodes,
think two.
two in 6 months or three in 1 year. Okay,
Mm,
then you will say that this is recurrent UTI. What are the risk factors for recurrent UTI in premenopausal woman? What do you think?
mm,
Short urethra. Okay. Then proximation of urethra to the anus. So the rectal flora, it may also contaminate the urinary tract. Okay. Then if she is sexually active and she is not maintaining her hygiene, it may also cause some problems. Coital trauma can cause it. Okay. And
mm,
if she has some other conditions like she has diabetes, then this is also a risk factor for causing UTI. Previous history of UTI like that. Then
Mm.
previously untreated or partially treated UTI. So, or if the response to the therapy was not seen. So, anytime your patient has UTI, she is coming to you. We are running the urinary test, urinalysis, confirming the diagnosis. If we need to check the sensitivities, we are doing the MSU and for culture and sensitivity, and then 7 days or 5 days after the therapy, usually 7 days of the therapy. Okay, we are
Mm.
going to repeat the urinalysis because we want to see that now she is clear of the infection. So partially or untreated UTI. All of these are risk factors, okay,
Validated.
if she has constipation. So now if this woman, she becomes pregnant, how will you manage her condition?
I will طيب if she can bring me I will لا. Okay, first
Remember,
I would go with the first I
mhm,
will try to just more assist prevention as much as we can, and we do a culture every trimester,
mhm.
even if it's asymptomatic. Will ask her to increase her food intake, drink cranberry juice. Um, what else she can? Um,
Yeah, cranberry juice is fine. Yeah, she can.
yes, maybe after sexual intercourse that she can clean the area just to reduce the risk of infection. If she has
Mhm.
recurrent infection while she's pregnant, we might offer her um, what do you call it? Prophylaxis dose of nitrofurantoin.
Mhm.
Um,
So you can give nitrofurantoin throughout her pregnancy?
no, we can start from second trimester until from the beginning
36
until
36
6 weeks
weeks.
something. Yeah,
Won't give after. Why you will not give after 36 weeks?
as there's risk of hemolytic anemia for the baby.
Hmm. Of the excellent. That is the point. Okay. So this patient will need assessment. You will do the urinalysis, okay, to see that she is not having infection right now. Then on each visit, we are going to do the urinalysis, and I'll be very careful between 9 to 17 weeks. That is at that time we have the highest incidence of UTI.
Mhm.
Why she is more likely to have the UTI during pregnancy? Because she has this relaxant effect of the progesterone, so the urine is going to stay in the bladder, so it can become contaminated. Otherwise, the urine should be sterile. That is one thing. I will tell her about the techniques to wipe herself from wash herself from front to back. Okay, that is one thing. Then, if she has and she should take this daily suppressive dose of the antibiotics, suppressive dose. Okay, nitrofurantoin is good, but several other things can also be given, so that we will decide in consultation with the infectious disease specialist. Then we will, at the time of booking, we would like to run ultrasound on her because we would like to see that what is the size of the ureter. Is it dilated, or because it is going to dilate during pregnancy? So what is the status right now? How much urine she is retaining, okay? And I will keep a low threshold for treating the infections because you will have to give them multiple drugs at that time. Maintain perineal hygiene. That is one thing. Cranberry juice because it will prevent adherence of the bacteria to the bladder walls. Then I will counsel her about the signs and symptoms of the pyelonephritis because the UTI, it may progress to pyelonephritis and it cause death in 20% of the patients. It may cause full-fledged sepsis. If there is sepsis, it can cause miscarriage, it can cause chorioamnionitis, it can trigger preterm labor and delivery. That is one thing. That's what we are scared of. And it may also lead to emergency delivery because the mother is going into stress, so we have to deliver the baby like that. Okay, and we also need to give the prophylactic um, antenatal corticosteroids and neuroprotection, Megcel, to this woman. Okay. And if the woman is having chronic infections, then we have to review her more frequently, every 1 to 2 weeks, and I will counsel her that even if she will have this asymptomatic bacteriuria, we will have to treat it like that. That is one thing. Okay. Now, what are management options for recurrent UTI in women in general? Generally, what will be your advice?
Frequent UTI. The same advice for the pregnancy, actually. I would
Yeah,
tell the patient to go to frequent urination,
yeah.
and decrease what do you call it? Increase or increase fluid intake. Link cranberry use. Avoid acidic. What's it called? Avoid acidic usage such as pineapple,
Spicy
um,
foods, yeah,
spicy
she should
food is.
avoid very much spicy foods because of she will have symptoms of interstitial cystitis. Okay, she should maintain perineal hygiene and she should
Brilliant
use
hygiene.
water-based lubricants during sexual intercourse to prevent trauma because trauma is the basic thing which is going to trigger it like that. Okay, wash herself, wipe herself from front to back. That is one thing, okay? And if they develop symptoms, they should seek help early, okay? That's all
Seek
you
help.
need to tell them. They should take adequate amount of water. Don't self-treat the condition with the home remedies. Get full assessment done.
And you
Why?
still,
Because yeah,
we can give her Nitifarantoin 50 milli, 1 milligram, 50 milli, 1 milligram daily, as well as
this
dose,
is
I think,
general.
for 6 months.
Yeah, general population don't give nitrofurantoin. Give them Bactrim. Bactrim is the best one according to ACOG. What is in the Bactrim? Sulfamethoxazole and trimethoprim. Okay, so you can give them Bactrim daily dose.
What the dose it does is it 100 or 400 something?
Yeah, 100
Oh,
mg VD. You don't have to remember the doses. They should not be asking you. That is job of the pharmacist. Just remember, pregnant, nitrofurantoin, stop at 36 weeks. Okay. Don't give Bactrim in the first trimester. Bactrim can be given in the second and third trimester, but again, because of the sulfamethoxazole will do the same thing as nitrofurantoin, so you need to stop that before at
36.
36 weeks. Okay. Can we give ciprofloxacin during pregnancy to treat UTI?
No, we can't. I
We
think it is
cannot.
called.
Because, yeah, it will cause teratogenesis like the tendon rupture in the baby. It can occur. But you have the option to give amoxil and you can also give them cephalexin. Okay, that is the thing. Give our information, tell about the website, patient information leaflet, and the sport.
طيب. Third case, 16 years old, retired nurse. What she came with, present with the gynecology clinic with 2 years history of urinary frequency and incontinence. 68 years old, she's postmenopausal. History of urinary frequency and incontinence. Maybe in the multiple medical issues in the past. What's your differential diagnosis of this patient? Please take focus history. Indication of what's indication of the first language for this patient. So his frequency and decrease in incontinence, he has changed the bad because this okay. Okay, I will start.
Yeah.
طيب, what's
What
your
is the
أو
differential
ما
diagnosis of, sorry, what is the differential diagnosis for urinary incontinence?
the most common is cyst incontinence, mixed incontinence or urge incontinence
So, fecal incontinence,
of
okay, neurological condition, metabolic
without
disorder,
condition
medications.
medication.
Okay. So, what will you like? How you will take a focused history from her?
I would go first. I would go first about her urinary incontinence. Does she have? Does she have? Is it coming with cough? Is coming with activities? How many times she goes to the bathroom per day? How many per night? Does she have urgency or urge incontinence? She can hold food until the bathroom. Um, Does she feel that she's is his incontinence urine coming continuously, or coming with coughing only? Does she have any 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 vaginal heaviness from down there? Um, does she have vaginal heaviness from down there? Does she have any issues, any surgical history before, such as gynecological history, or hysterectomy or myomectomy before, or any urogynecological surgery? Um, she's diabetic, hypertensive, blood sugar control or not? She's had any neurological diseases such as what's it called?
Yeah. So basically, you
خلاص
need
نسيت.
to ask her that it is associated with activity or without activity, at
مم.
rest or with activity, like that. That is one thing. And then, does she realize when it happens or she doesn't? Because if she
مم.
realize she notices that it has happened, then it means that her nervous system is intact. If she
مم.
doesn't know, then she doesn't know. Rest of the things, yes, I will agree with you. And the children she has, how many children she has, para three, so how they were born, normal or like
مم. or
and but for the weights, like that. Okay. And she have any medical problems? Because in the history they said that she has multiple problems. Okay. So what would you like to do as part of your pelvic exam?
initially I would go for height and weight, sorry, vital signs, height and weight. Um, her BMI, is it obese or not? I would look for after that for quickly for abdominal examination, is there's any masses or not. Sorry, I would go for pelvic examination for شو اسمه. I would go for شو اسمه for barbecue test if she has any prolapse or not. I would go to cuff test with using to speculum to see if she's leaking or not with cuffing or not. I would do for Q-tip test. I would do for the patient by manual examination, BR to check for any mass filling or not. I would do for BR examination. I would do for perineal sensation examination as well. I can do for the patient as well if I have anything, if there's no clean no clean source from the for what you call it for leaking for me. We can do for dye test
Hmm.
uh,
Why
to look for
dietist?
the causes. Um,
Hmm.
if I didn't see anything coming, or if I see something coming continuously as a suggestive of continuous leaking, we can do the dye test. And
That
that
is
not
one
nothing for
thing.
me.
So, but we need to take consent. Okay. I will
Oh, that.
I will take permission from her, explain to her that what I want to do. Okay,
Mm.
in the presence of a chaperone. Okay, that is one thing. And when I will and why you didn't inspect the patient? Because we said that we have to look at the vulva also, and then we
After.
have to look at the pelvic mucosa as well, and the
بس
urethral
لك
area also, like that. Okay,
بس
it's
أنا
the
بتروح
area like,
كيف.
yeah, atrophied, or maybe she has like some lesion, something is over there. Okay, so make it a point that start with the inspection, palpation, then we are going to do the VE, like that. Okay, and do the rectal examination as well. You need to check the tone of the rectum as well, like that. Okay, all of these things. Rest of the things, yes, they are fine. Okay, so what are the indications for urodynamic studies? Now, this is a loose ball. Can be many indications, but now you have a patient who is like 68 and she has got the problem. So talk about this patient only, okay? In the Osce, your challenge is to talk about the patient given in the scenario, not about everyone. So in this patient, what will be the indications for urodynamic studies?
Mm. Okay. Uh, to look for the function of bladder and urethra,
Yes.
to confirm our
Yeah.
diagnosis of to confirm or exclude stress urinary incontinence or disorders of activity,
Mm-hmm. Okay.
and to look for sorry and
You can say
um,
that, yeah.
to
You
look
can
for
say that.
شو
Mm-hmm.
اسمه the storage function of her and the
Okay.
pointing function of the urethra of the bladder.
Okay. So that's very good, but you can also say that you will do it. Indications for urodynamics. If patient doesn't respond to lifestyle modification,
Okay.
the likely modified the fluids and the pelvic floor therapy. If she didn't do that, or it failed in her case like that, okay?
Mm,
Or when we are sending the patient to the secondary care for the specialist review or for the multidisciplinary team review.
mm,
Urogynecology, actually, it has to be managed by a team of the specialist people, like, okay, the urogynecologist, okay, your OB, your gynecologist, then this nurse specialist, nurse, the correct nurse practitioner, okay, who can be like a continence advisor as well, and the physiotherapist also like that, okay. That is one thing. This patient, these are the indications, okay. Or if she has like mixed symptoms, so the symptoms are like the symptoms are changing, or failure to respond to the initial interventions, then we are going to do the urodynamics, or if the patient requests. That is one thing, okay? So let's say that after the testing we have found that she has urinary incontinence. Then what are the first line management options for your patient? So are the drugs first line?
No,
What
it
is your
is
no, they are second.
usually lifestyle modification as usual.
Yeah,
Lifestyle
yeah.
modification, behavioral therapy, including including reduce fluid intake, reduce caffeine, stop smoking, behavior therapy, and refer for physiotherapy for at least 3 months. Um, that
Bladder
and
training.
bladder voiding function,
Yeah.
dairy, and there's something else.
Bladder
Mm.
retraining, okay, which I tell her about the bladder
Brother training
training.
you.
That is one thing.
Mm.
So that is the thing, okay, that you need to tell her. Just the general things, that fluid management, like we said, we already said, talked about that in the behavioral therapy. And we can also tell her that if she is a working woman, she should move her desk closer to the washroom door. Okay, that is also one of the things. Time voids like
Mm.
that. That is one thing. So for how long she should get the first line management for if she has urgent continence for 6 weeks, and then get herself reviewed. If it is
Mm.
stress urinary incontinence, then give her chance for 12 weeks. Let's go to this one.
48 years old. طيب 48 years old woman seen in the office for persistent urinary frequency and pain. Persistent frequency and pain. This antibiotic, the best done shows hematuria. She is very upset about condition. What your focus history in this examination you will do in her? What's your differential diagnosis? What's your first line? Frequency. Okay. Hematuria. It's just status.
So, what is the general impression? What can be her problem?
Um, resistance frequency and pain could be including insufficient status or and hematuria can we're suspecting going on with the bladder cancer.
Mm-hmm.
So or recurrent UTI. This is my impression.
Recurrent UTI. So, why not interstitial cystitis, painful bladder syndrome, atrophy? Look at always, why
Mm,
are they giving you the age? Age
okay.
is
Mm,
there for a purpose, or on
mm,
purpose. Like a
okay.
young girl is going to have different causes, and the older people, they are going to have other causes like that, okay. So it is not responding to antibiotics, so it means that there is no infection, there is something else like that, okay. So this is perimenopausal age group, okay.
But,
So maybe she's having this atrophy. Start with the simplest things, okay. The bladder cancer is very, very rare, transitional cell carcinoma. And
mm,
remember that in the younger patient, the most important causes would be infection.
at
In the
infection
older
basically.
patient, in her 60s or the 70s, the cause would be cancers like that. Okay. So the 48-year-old is going to have 101 causes like that. Okay. That is one thing.
Mm,
So What will you ask on focus history of present illness?
طيب. I'd go simply with UTI symptoms. Does have to see or not, any frequency, an increase in frequency, any painful urination, and how many times any painful urination. Um,
At
um,
night and during day. Okay?
and at night
Because
during the day, yes, you
nocturia is a feature of urgent
urgent,
conscious.
urgent contraceptive.
Yeah.
After that, I would go with her gun history. She's menopause or not. Does she have any history of house period? Does she have any history of any painful period or currently dyspareunia? His regular period or not? When the last period she have it? Does she need to use lubricant for for intercourse or not? Then I would go for then I would go uh, for her pain. Does she receive does she receive treatment before for the same issue? Did she did any investigation? Did she did any culture? Did she improve or not on it? Um, did she was seen by specialists before? Um,
Okay. Enough for a
this
focus
one.
history. Just ask about the main things. And when she's passing urine, it is coming in the start, or the urine is mixed with the blood, or she is passing urine at the end of micturition, like that. Okay.
Mm,
Because if she's having in the start, maybe this is urethral. Okay. If it is generally mixed and the brownish, then it means that maybe she's taking anticoagulants, or maybe there is something like some other disease process is there, like she was taking warfarin and she is having disturbed coagulation system, like that. Okay.
mm,
Or she has massive infection, she has schistosomiasis. If usually she's passing this at the end, so maybe she has some part of the tumor or something is coming out, like that. Okay. And does she feel any bulge, any heaviness? Has she lost any weight recently? Patient has hematuria, so weight loss, that is one single thing. How has she lost
mm,
any weight changes in the recent time? Because the cancer patients, they will have cachexia, and so they are going to lose weight, so we are going to ask about that. That is one thing. And this is painful or painless. Painful, yeah, here they already told you that she has urinary frequency and pain, so this is going for the interstitial cystitis.
mm.
What examination you would like to do on her?
Okay, I would go initially with شو اسمه.
General
This include
appearance.
okay, this examination. Okay, طيب.
Mhm.
I thought investigation. Examination will go general appearance here be my the fatigue statistic or not. Um, After that I would go for شو اسمه for any lymph nodes, lymphadenopathy, cervical lymphadenopathy, chest and respiratory, if she's any it's sounded or not. I would go to abdomen, soft lax, if she's any mass felt. And then I would go for pelvic examination. I would go for I would go for inspection first. If she's any sign of atrophy, if she's sign of wrinkled skin, if she's kind of of it's called, if then after that I would go for examination. Examination of sign of prolapse. I would do barbecue. I will let her see if she's leaking urine with complex or not. BR examination by manual and to check of fecal tone, or if she have any impacted stool. Um, I would do by manual examination, as I said. Um, I could do كمان even urine dipstick to see if I can do to um, for any leukocytosis.
Mhm.
What else?
Okay.
خلاص this is it
So
from me. خلاص ما في شيء.
when we are taking the history, anyone who is passing urine, passing red urine, and she is feeling like she has pain also, so her mood is going to be like very low. Okay, I will
Mm.
ask about the history of depression, any change in the behavior and the mood like that. Okay, and what is the effect on quality of life. So these two things are very important like that. Okay. In the examination, again start from the inspection, VE with her permission, and you're going to ask her, and then I will look with her permission. You are going to do that in the presence of the chaplain. You are looking for the pelvic floor defects for the neurological signs and symptoms, tone of the pelvic floor, muscles like that. And then is there any irritation and what is the condition of the vulval skin and are there any lesions on the vulva or in the vagina or around the urethra? That is one thing, okay? And you will also like to palpate the anterior wall of the vagina because you would like to exclude urethral diverticulum. In the history, we should know that how many children she has and what were the modes of birth and what is the age of the last born baby like that, okay? So what is your differential diagnosis here? Hello, can you hear me, doctor? Hello. Hello. Hello.
أقول اللي صاير.
Yeah, I can hear you now. Can you hear me? Hello.
ألو دكتور، ألو.
Hello. Yeah, yes, I can hear you. Hello.
Yes, Doctora, we can hear you.
Okay, that's wonderful. Thank you for confirming. So, Dr. Muhannad, I think he's having some problem. Okay, so he is not responding. So, can you do this station for me till the time Dr. Muhammad is able to rejoin us? So, will you like to do this station?
Okay, shall I try?
Yeah, why not? Yeah.
Okay. 48-year-old woman is seen in your office for persistent urinary frequency and pain not responding to antibiotic. Domestic done at walk-in clinic showed hematuria. She is very upset about her condition.
Yeah.
So, what you will ask when focused history and present illness. Okay, I will ask her when this symptoms started
Mm-hmm.
and
This
creating
conference will now be recorded.
So, sorry. Yeah.
okay.
Yes, please.
What what are the things that aggravate the symptoms and what are the things that alleviate her symptoms?
Yeah.
Uh, does she have any dysuria while she has she do micturition? Is there burning in her micturition? Does she feels complete emptying of her bladder and the flow is strong or weak? Um, Also, I will ask her if she has postcoital bleeding. I will ask her if she has constipation or she make digitation or invagination while she is urinate. She has micturition. Um,
But when was her LMP, and is she using any
Yeah,
form of contraception, any form of family planning? Is she taking any other drugs like the blood thinners,
yeah,
aspirin?
yes,
Okay.
yes. I will ask her if she is a smoker, if she
Mm-hmm.
is an alcohol, recreational drugs. I'll ask her about her occupation and as well her family history of malignancies.
Yeah.
Yes,
Family history of malignancies, family history of blood clots. Okay, these are the things.
yes,
And so all of these things, and how is her mood? What is the effect of her condition on her quality of
yes,
life? Like that. Okay.
yes,
That is one
yes.
thing. How many children she has, what were the modes of birth, and did she sustain any injury at any
Mm,
time, like that. Okay.
mm-hmm.
So, what examination you will like to do on her?
Okay, I will do general examination. I will check her face, if she has pallor or not, any symptoms of anemia, thyroid, neck, thyroid, if she has any thyroidomegaly, thyroid enlargement. I'm sorry. I'll check her chest, breast, abdomen if there is any skin striations, scars, pelvic masses. I will do local pelvic examination. First of all, I will do an inspection if there is any discoloration or abnormal or any abnormalities, any lesions. I will do speculum examination, split speculum examination. If there is any atrophy in vaginal epithelium, uh, I will do cuff test and occult cuff test while the bladder is full, while she's supine and standing. Uh, a Q-tip test, if it's more than 30, she could have
Degree.
yeah, more than 30 degree. She might have hypermobile urethra. I will do uh, rectal examination if there is any masses or something. I will do also for sensation for pudendal nerve is to anus for examination by this needle or by swab the sensation. Yes.
Any any
I,
secretions, any smell?
any vaginal discharge or foul smelling. Uh,
Mhm. Yeah, that's fine. Any abnormal mass, any asymmetry, any pigmentation, okay? Any disfiguration, anything like that, okay? That's all. So, what
uh-huh.
is your differential diagnosis of her condition?
She might have urethral diverticulum, um, recurrent UTI, bladder malignancy, um, interstitial cystitis,
Mm-hmm.
um,
Schistosomiasis, okay? So, history of travel would also be important here, like that, okay?
mm,
That is one thing, okay? And does she pass any gravel at the end of urination, like that? Okay, she is passing only blood, or she is passing some salts also, like the gravel, she is like the sand. Is she passing something like that? Because that will point towards the this schistosomiasis, like that. Okay, it can occur
yeah,
like people who are going to the beaches, they can get this this infection.
mm, mhm,
That is one
mhm,
thing. So on her assessment, you couldn't find any specific cause.
mm.
So, would you like to do any other tests on her?
Yes, sure. I will do urine analysis, culture, liver panel, renal panel. Uh, I will do ultrasound, cystoscope,
Mm-hmm.
and cystourethrogram.
Try cystourethrogram. Cystoscopy is fine. Okay, just do the
Cyst-
cystoscopy to
yes.
exclude any masses or anything. So let's
mm,
see that you have seen some ulcers on cystoscopy.
mm.
So what will be the first line conservative management option for this patient?
Uh, Hanner ulcers.
Mm-hmm.
Uh, First line of management in interstitial cystitis. Um, yeah. First of all, stop smoking, caffeine
Mm-hmm.
intake, uh, acidic fluids. Um,
Yeah. Decrease stress in her life. Don't take spicy food. Okay. Take healthy
yes,
food, exercise, CBT,
yes.
talk to someone. I will refer to the psychosexual counselor for the
Mm,
counseling. Okay. And she should
mm,
not be taking spicy food, plenty of water, and
yes.
decrease stress in her life like that. Okay.
Mm-hmm, mm-hmm.
That's all you need to do. So we did this, and still she has not improved much. What will you like to do now for her?
Um, I'm not sure. I can't remember. We can do like fulguration of these ulcers.
That would be the last step like that, okay? In the workup, so in the history that we have asked about the mood, thorough medical history, physical exam. Again, ask her for the 3-day bladder diary because maybe she's having some problem. And in addition to that, you will ask her to keep a food diary because if there are specific foods which are aggravating or causing flare up of the symptoms like that, okay? We need
Mm,
to exclude UTI, like you said. That is the prerequisite basically for the diagnosis. At the same
mm,
time, when I asked about the discharges, that was your clue that we need to exclude the vaginitis, which could be due to ureoplasma, mycoplasma, because all of these are going to cause friability because of the inflammation. Okay, and in the symptomatic patients with the negative urine cultures and pyuria. Okay, urine was negative, didn't tell us a story, so we need to test for the infections, and these are in the urine. Look for other infections. Cystoscopy, and then it may means, and then referral to the urology. It should be done according to the local protocols. Remember, the guidelines are different everywhere, like that. Okay,
mm-hmm,
so the first line management, remove the irritant. Okay, and what we can do, like this is remember, this is the diagnosis of exclusion. Okay, at cystoscopy we are going to take the biopsies. Biopsies are sorry, are not indicated. You have seen the lesions, that is enough like that. Okay, and
mm,
then we need to say that cystoscopy does not confirm or exclude the diagnosis, but it is required to diagnose or exclude other conditions that mimic interstitial cystitis. That
yes.
is not diagnostic. Diagnosis is that of the exclusion. Okay.
Mm,
Then the urodynamic testing. Okay. And the urinary, we like to test the serum electrolytes into the urine also. Urinary electrolytes, they are not required. Okay.
mm-hmm,
Urodynamic test, if we will consider if your patient has the symptoms of the overactive bladder also like that. Okay, and they have the symptoms which are voiding symptoms which are not like specifically identified, non-specific symptoms like that. Okay, so going back to the treatment, the first line would be you have done everything. Okay, if there is you have done everything, everything is negative, then you will consider malignancy, infections, overactive bladder, bladder stones. Bladder stones are a very important pathology. Then outlet obstruction, prolapse, because what happens in the prolapse, the urethra is pulled out. Endometriosis is very important diagnosis. So again, the duration of the symptoms is very important. Any exposure to radiation or the drugs, because or the how were her smears, that we need to ask in the history, because if the patient had history of abnormal smears, maybe she had cervical cancer and now she's having radiation cystitis. Like in your written exam, they are always asking about the radiation cystitis. First line management conservative. We can give her analgesics like the smooth muscle relaxants, stress relief, dietary modification, exercise, physical therapy. Support group. And if the treatment fails, this is the time we need to go to the secondary care. In the secondary care, they can give her the tricyclic antidepressants like oral amitriptyline can be given. That is a good analgesic. They can give her cimetidine also because it has the more. How does it relieve this cimetidine? We don't know much about it. If this first line treatment fails, then we are going to refer her to a multidisciplinary team and the specialist pain clinic, okay, and the clinical psychologist. If that doesn't work, then we need to give her DMSO. We can give her this one. Then we can give her heparin. We are referring her to the secondary care for further management where they can give her different drugs. They can give her botulinum toxin. They can also give her lidocaine, and they can give hyaluronic acid, chondroitin sulfate, and then if this is not working for her, then we have the option to give her what? We can give her neuromodulation, just like we do in all chronic conditions like that, in the urinary conditions. Okay, so neuromodulation, they will not ask you in detail that what is this thing. So then what else can be? Behavioral therapy, it will continue all the way like that, okay? And then it is not, then we can also give her, what else you can give her?
We gave her
So this
everything.
Mhm.
Yeah.
Yeah, please go on.
Uh,
Yeah, this dimethyl sulfoxide is very good. Like most of the patients, they will respond to this therapy. Okay, dimethyl sulfoxide is a good thing. If it doesn't work, then you have given botulinum toxin because you are going to relax the bladder so that the patient will not be passing the urine very frequently. And the lidocaine can be given again, the painkiller, chondroitin sulfate, hyaluronic acid. Okay. Why hyaluronic acid? Because it is going to maintain water, so it will be moistened, so maybe she will not have that much pain. So neuromodulation, if it is not, or we can give her immunosuppressive therapy in the form of cyclosporine. Nothing working, then the fifth line would be cystoscopy and hydrodistension. And after that, like the lesions are there, then major surgery is considered. It will mean that prefer to the tertiary care. But there is like, if you are seeing only the spots, it means that still you can treat the condition. But if you are seeing the like the large lesions are there, then you are going to refer her to the higher center. Here also, I know that the conflict here is always this one, that why are we not sending her for cystoscopy and the removal of the lesions? Because this patient, we don't know what is the history. She has a, if she, in case she has short history, then we are going to start first with the um, lifestyle modifications. If her ulcers, they don't heal with simple interventions, then this is the place for the more radical surgery, which is beyond your scope. That will be job of the urologist. So give her short trial of therapy, first line, second line, third line, weekly visits. She's improving, well and good. Not improving, then we are going to refer her to the secondary care for further management. Sport would be very important. Psychological support is very important. Sport groups are very important. Okay, these things should be there. They don't want you to manage her condition definitively. They just want to see that, do you know that you are going to manage her in a stepwise manner. So say that there is a place for the multidisciplinary team management. Who will be on your team? Mention that, and what are they going to do? They are going to make the patient's life easy. Like patient should relax, and if she improves, well and good. If she doesn't, then we have seen large lesions, then we are going to get her surgical care, refer her to the secondary care. I will document everything in her notes, arrange follow-up, and review her. Give her patient information leaflet, number of a person who is responsible for her overall care. That's all you need to tell her. Okay? Give her PIL and schedule another appointment. Any questions, any conflicts, any issue here? Hello, are you guys hearing me?
yes, doctora. Yes, doctora.
Okay. Let's go to this one. Dr. Muhammad, are you hearing us? If you, then you can do like you can take turns. But if still there is internet problem, then doctor, you can continue.
Yes, I can hear you, دكتورة.
Okay. So will you like to do this case number 5?
Oh, this prolapse. Okay.
Yeah.
Mm,
Okay. Okay, doctor, next one for you.
This 47-year-old Mr. Masoud, para 5, presented with mass proceeding with vagina from 1 year and difficulty in initiating maturation. طيب. Okay. What will you ask in detailed history? طيب. What's the common urinary symptoms and prolapse? And the urinary retention maybe. Sure, that was the important point. طيب, okay. I will go ahead.
You can start.
بسم الله.
What can
طيب,
you tell
okay.
me about this case, this patient?
This patient, perimenopausal woman with para 5, came with with mass protruding per vagina with
Mm-hmm.
and difficulty in urinary and micturition, initiation micturition.
So, what details you would like to ask her?
First, I will ask about her age, her occupations, her age, her occupation, أيوة. Then after that, I will go for the detail for the when this started with her, this mass exactly. Does she feel happy with this? Does she feel, do you have any constipation, any urine retention, any urine retention, any dysuria? Does she have issue with her? Does she have dyspareunia? Does she need to? Does it need help with the micturition or reduce the mass to micturate or defecate? طيب. Does it affect the quality of life? Does she have any does this mass does he need to wear pad to go around for this anyway, does his affect quality of life? Then I'll go for her history of her obstetric history. Was it her vaginal delivery? All vaginal delivery? Do you have any vaginal delivery? She has any history of for insulin delivery, any prototomy and third or fourth degree tear. Any complication following that? She has any history of any complication valid fistula or not. Following that, I would go for her gynecology history of his her period is normal, regular period, no issue with it. Does she have dyspareunia, dysamenorrhea, the pap smear, STDs histories, and PID? I'll go after that to her medical history. She's diabetic hypertension. Any comorbidities, heart disease. I will go to the surgical history. Following that, if any surgical history, either any vaginal any bear, any section, any mammectomy. Then after that, I would go for family history and history of breast cancer in the family, and history of conjunctival tissue disease, and history of after that, I'll go for her medical history, any allergies, any medication she's taken, any vaccination, social history, she's occupation, and she's smoking, smoker, alcoholism, and drugs. And this is it for in the history.
Yeah, any cough symptoms, medical comorbidities, neurological conditions like that. Okay, and what is the effect on quality of life? What is the effect on her sexual function? And how she looks at herself and at her condition. The thinking of the patient and how much she is disturbed, it is disturbing for her. It's very important for you to know. Okay. Okay. So what are the common urinary symptoms in if the patient has a prolapse?
I think it is urinary retention.
Yeah,
Um,
urinary retention
retention,
frequency. Okay.
and retention
You
frequency
can say
UTI.
poor stream. Yeah,
Mm,
poor
frequency
stream.
UTI.
Then I said that patient can have immense hematuria because of the prolapse. What is
Immature.
happening? Remember that this is all soft tissue. Something is
Mm,
pulling down, so urethra can be prolapsed. Okay, so there can
mm,
be irritation, and the patient can have a bleed. That is one thing. She can have difficulty in initiating the
mm,
micturition. She will have dribble, and she has to go to the bathroom all the time, and she will have a feeling of something protruding down below. Okay, and a feeling of mass, and she can have backache as well, lower abdominal pain like that. Okay, and she can have low
mm,
mood and depression because 1.5 year is a long period of time. She will be depressed as well like that. Okay,
mm.
so here they have shown you a diagram. What do we call it?
This PubQ diagram.
So pelvic,
PubQ.
don't use the abbreviation, okay? Pelvic organ prolapse quantification system grade.
Mm,
This is the grade, okay? Or a grade, and so this is the
prolapse.
tool, okay?
Mm,
Anything, any paper that you use to tell the patient about anything, that is called a tool. You are taking the help of the tool, okay? Even this ice bar, that is a tool.
mm,
Meos, that is also a tool because they are helping us in our function. So how do we describe it?
mm. Should I describe how do
The
it? Well,
pop,
what do you mean?
yes, the pop cue. Yeah, you will tell them that what are these things. Okay, start with them. That basically you are going to measure 6 points. Okay, like that.
I will take the consent for the patient. I will measure. I will tell what I'm doing with the exam. That I need to use this speculum for examination. I will measure almost 6 measure, and I will measure the genital. What do you call it? I will I will measure 2 point in the anterior. Uh, in the anterior pelvis anteriorly, and 2 measure posteriorly in the vagina.
Mm-hmm.
Um, until شو اسمه and then the two major will be the most proximal and most distal prolapse of the part of the prolapse,
Mm-hmm.
and I will measure the position of the cervix. I will measure the length of of the vagina, and I'm not sure how can I say
This is
the
if you are explaining the grid, so you are explaining to the medical professional. Okay, for the
mm,
patient, you will say this is just a tool which will help me assess your condition. That how bad it is. Okay, that is one thing.
mm,
And for the examiner, you are going to say that AA is going to represent the part proximal to the introitus. Okay.
mm,
PA is the part distal to the hymen, plane of the hymen. C is the location of the cervix, which should be in a normal condition. It should be 3 to 4 centimeter away from the introitus. GH stands for the genital hiatus. Okay,
mm,
this is the opening out to the vagina like that. Okay. PB, this is the perineal body. Perineal body where the all muscles of the this is the area where muscles from all directions they are meeting, and this is the strongest point. And this is the area between the vagina and the rectum like that. Okay, that is a and the total vaginal length, the length from the introitus to the
mm,
apex of the vagina. Okay, on average
mm,
can be 8 to 10 centimeter. That is one thing, okay? And then similarly, AP is the wall point on the posterior wall proximal to the introitus. BP,
mm,
that is the part distal to the introitus towards the cervix. D is the pouch of Douglas, and if the patient has undergone hysterectomy, he won't have a point D. Okay,
mm,
so this system is helpful in telling us that where is the prolapse and how bad it is, like that. Okay, so we will put that um, if this is zero, it means that everything that the cervix and the walls they are in their normal position and they're not anywhere. So there is a method of quantification it also like that. Like what do we do? Like we tell them that this is grade A, B, C, D, or E like that. Okay. So that's how we are going to describe the this one, that what is the degree of the prolapse and how we are
Mm.
counseling them, that what exactly is happening to the patient like that. Then what is that thing? Ah, okay. There is a system of telling them as well like that. Okay, prolapse patient. This is post-hysterectomy want prolapse, but the same things you can use for this one also like that. For the pop, you like the history you have taken, and you people are mentioning the urinary symptoms all the time. You have to talk about the bowel symptoms also. Okay, and sexual function and the desire to retain the sexual function like that. That is one thing. Okay, pop q assessment, this is based on the demonstrating the maximum extent of the prolapse. You want to see that what is the maximum. Okay, what is the maximum? Like when the patient is the vaginal wall becomes, they will not ask you about the definition, so you just say that what is the maximum point of the prolapse. And the fixed point of reference for all POPQ is the plane of the hymen. That is the reference. Above above that one, you can see 2 points are above that plane and two are like closer to that one. And if a patient has like prolapse, then everything will be coming below the plane of the hymen. Point AA located at the midline of the anterior vaginal wall, 3 centimeter proximal to the external urethral meatus. Okay. -3 means it may be located anywhere from -3 centimeter above to +3 centimeter below the hymen. If it is below the plane of hymen, then it means that the patient has prolapse. If the sign they give you, they will give you a result and they will ask you to interpret. If this is negative, then this is not negative prolapse. Remember it like this, okay? If it
Mm.
is positive, it means the patient has prolapse. That is the way to remember it. Positive is equal to prolapse. Negative means nothing. Point PA, the most distal part of any part of the anterior vaginal wall. Again, we should know that the distance, by definition, the distance between the point A and B, it should be 8 centimeter, -8 centimeter. Okay, that is one thing.
Mm.
Then the other points are located in the superior vagina. C is the most distal edge of the cervix or the leading edge of the vaginal curve after hysterectomy. The point will be the C even if the patient had hysterectomy. D is the deepest part of the posterior fornix in the woman who still has a cervix. Maybe she had subtotal hysterectomy or maybe she never had any surgery. The uterus is there and the point D is there. Okay. Usually it is located where the uterosacral ligament attaches to the posterior cervix. That is one thing, okay? So the D, it will be omitted in the absence of the cervix. Patient has no cervix, so there is no D point. Cervix is there, so the D point is there because the area behind that on the superior vaginal wall, it will be, or the vaginal wall, that will be the point D. 2 points we are going to assess on the posterior vaginal wall, and they're just like the 2 points on the anterior vaginal wall. Point AP is located in the midline of the posterior vaginal wall, 3 centimeter proximal to the hymen, and this point ranges from -3 in the normal, -3 is in the normal, to +3 when there is complete prolapse. Similarly, point B, that is the most distal position of any part of the upper posterior vaginal wall from the vaginal cuff or the posterior vaginal fornix point, and that can again be -3 when there is no prolapse to the +3 when there is prolapse. It can also be like in the post-hysterectomy, it may also come out and there can be vaginal eversion. If the cervix is there, then there will be genital prolapse. Okay, the vagina will be there, but the uterus will come out, the cervix like that. Okay. Genital hiatus measured from the middle of the external urethral meatus to the posterior midline hymen. The hymen is included in that, okay? Genital hiatus, okay? And the perineal body, this is measured from the posterior margin of the genital hiatus to the mid-anal opening. These are the 2 points, okay? The location and how, what do they mean like that, okay? Then important, you should know about the stages. That's why I pulled out this one, okay? Stage 0, no descent of the pelvic structure during straining. We will ask the patient to strain, like put pressure downwards, okay? So there is nothing. Stage 1, the leading edge of the prolapse. Okay, remember, if it is post-hysterectomy wall prolapse, then that will be the vaginal wall. But if the patient has like the genital prolapse like that, something is there, then we will say that the cervix is like more than 1 centimeter above the hymenal ring. Stage 2, the cervix, it is 1 centimeter above the hymen to 1 centimeter below the ring of the hymen. Stage 3, it is 2 centimeter between 2 and 3 centimeter. Stage 4, this is the complete prolapse. Okay, that's how you're going to decode this information for her. So these are the points that you will explain. So here they never asked you about the management or anything. So they have
Mm.
asked this question before. Okay, that how you will describe the this pop cue. So this is available in your notes. So make it a point to go over that. Okay, let's go to the next one. Thank you, Dr. Muhammad. This one for Dr. if she's still here. Okay. So will you please like to do this one? Hello.
She's around, دكتورة.
Okay.
She's
In that
around
case,
still, بس maybe she's.
okay. Okay. Then you can take this one.
طيب okay. This patient, she is 28 years old, Mr. Samdani, brought to patient with third-degree uterovaginal prolapse. Uterovaginal prolapse. How will you proceed? Stage 3. How would you treat the patient? What are the components of magister operation? طيب okay.
So this
طيب.
is
This patient,
minor.
she's stage 3 prolapse.
Yeah.
That means she's beyond the hymen, 1 centimeter, more than 1 centimeter, more than 1 centimeter beyond the hymen. What is this patient sling procedure? The patient she's having a bica prolapse mainly.
Yeah.
We can go for sling procedure such as sacrocolobexy or what the other one? Sacrocolobexy. الثاني شو اسمه؟
Okay. So
أنا
I
ما remember
think
الثاني.
don't worry. It happens. Don't worry at all. It's a bad station. Okay. So I want you to go over these procedures. Okay, because they really like to ask you that what are the sling procedures. Okay. How do we do them? And what are the benefits and what are the drawbacks. Okay, you will get some help from here, but you have got some other notes are also on your web page. Okay, so don't worry about
I have it. I studied the exam, but now I forget.
it. Yeah, that is, and this is the simplest one like that. Okay, remember, in one you are just sporting the urethra like that. Okay, I will not tell you that which one is this one because I want you to go over it. Here is the detail. Like, you don't have to remember many things, just this is the filtered information, that's all. Okay, now look at the other procedure. Like, we are going around the whole thing like that. Okay, and you are sporting the middle urethra. The previous one you were sporting the just
But it is written there exactly. She has a uterovaginal prolapse, so the only thing applicable for her is
yes, she has the prolapse. So your first step is that you are going to see that what is the extent of the, they have given you that diagnosis. Okay,
mm,
so what procedures you are going to do for her, and because why this all of this thing becomes okay. You will not told why it becomes important. Look at the age of the patient. She is only 28
mm,
and she is para 2. Okay. and maybe she will, and obviously she will have fertility aspirations like that. Okay. So when you are telling them that I will not do this procedure, then you have to tell them that why this procedure is not going to help her, because the sling procedures and the things, these are for the stress urinary incontinence,
Mm.
and this patient has third degree uterovaginal prolapse. Okay. So you can do several things. Okay. So in stage three, you think that lifestyle modification like the Kegel exercises,
No, it's not.
physiotherapy,
Is that going to be helpful?
is okay. So you need to tell them about the negatives also. That why these procedures are not very helpful like that. Okay. That is one thing. So then what procedures can be done on her?
Initially, we can go with we need to ask our go history with the patient. She's desired fertility or not. She's desiring vaginal delivery later or not. Or tell her the risk of that if she the risk of شو اسمه هذا failure of procedure if she desiring vaginal delivery later. We can offer the patient non-medical, which is basically if she want
Mhm.
initially. Until she is complete her fertility, then we can proceed to the surgical management.
Okay. So if you have assessed the patient, and so if there is, as a general rule, if she has anterior wall prolapse, check for the posterior wall prolapse also, okay, because they exist. So basically, don't be confused by the name of this one like that, okay? So what do we do in the procedure?
The procedure, sacrocolpexy. There's sacrocolpexy. There is ثاني ذيك اسمه البرش procedure. I'm not sure. I don't remember. I don't know. I don't remember صراحة.
Don't worry,
I'm not sure.
Manchester's operation basically it is done if the patient has elongated cervix like that, okay? Can could be due to any cause like that, okay? So what we do, we just like cut the elongated cervix. We just separate the anterior wall and the bladder from the cervix, and then we try to cut some of the cervix like that. Okay, so you can say that this operation may not be very useful for this woman. We have other options. Okay, then they will ask you what other options you have like that. Okay, so this operation, remember, this operation is also is the same as the Fothergill's operation like that. Okay. So maybe I will tell the patient that she has other options also like that. What other options she has? Like we can do hystropexy for her. We can do hysterocolpopexy for her. Why? Because I will ask her what are the fertility aspirations. Okay. And now I want you to look up few points. What is hystropexy? What is hysterocolpopexy? Okay.
طيب.
And then what is the Oxford operations? Actually, in the exam, they should not be asking you by the name of the things like that. Okay. So in this patient, you need to establish, you would like to ask her another thing also. What about her? We never asked her that she's para 2, what were the modes and what was the duration of the pregnancy? Because if the patient has elastic tissue smooth, this muscular problem is there, elastin is deficient, then like Don Allard syndrome, then maybe she would have gone for the preterm labor like that. Okay, because 28-year-old patient presenting with this thing, so you have to think about it that what is the cause of the prolapse? She has any problems before? She has problem with her eyes, any history of the congenital, any history of the muscular disorders in the family? What about her pregnancies? When were the babies born? What was the duration of the pregnancy? Normal births or cesarean sections? If sections and births, what happened in the postpartum period? And if she underwent any operation, what was the post-op period like? Things were fine or not like that? Okay. Is she taking any recreation drugs? Anything? Is there any other abnormality? Has she been treated for any other condition like that? Okay. Then I would like to ask her what are her fertility aspirations. So here, and then you can also say that my challenge would be to reposition the uterus in the place and then keep it anteverted, because the anteverted position is the right thing. Okay, that is the right position for her. So how we can do that? By hysteropexy, hysterocolpopexy. So So you're going to pull the uterus and you're going to attach it to we can attach it to the sacral promontory, we can attach it to the anterior longitudinal ligament on the backbone. So whenever you are telling them about the procedure, basically they are asking you about the procedure and they are asking you that what you will do. So you need to explain the
Mm.
things to the patient. So first you should know that what surgeries you can do here, what are the pros and cons. So basically consent guideline. She can develop
Okay.
her condition can be treated completely, her condition can be treated impartially. Yeah, and she can have de novo voiding difficulty. She is so
Mm.
start from the right from the anesthetic from the period before the surgery. She will have to be admitted to the hospital. She will have to stay hungry and PO, and then we are going. She will need this thinners in the post-op period. What will be the duration of the procedure? Who is going to do the surgery? What type of patient you would like to do? What complications she can have. So always mention the anesthetic complications and the surgical complications. We will give her prophylactic antibiotics. She may have a reaction, but usually the chance is very, very low. We will have to catheterize the bladder, so that is also important. For how long we are going to keep the Foley's catheter depends that when she will be ambulating and when she will be able to go to the bathroom independently, or she will take the bed plans. Then during the surgery, she can have some certain complications. She can have anesthetic hazards, or she can have injury to the surrounding viscera, failure of the operation, and then immediate problems would be risk of bleeding and injury to the surrounding viscera because the area is like that. Okay. And then in the post-op period, she will require analgesics. She will have to stay on the HTU. We will have to keep the urine pipe inside her body. We are going to give her, she will have to stay hungry for a while, and we are going to give her the fluids like that. Okay, she will have to stay in the period in the hospital for at least 3 days. She will need the stool softeners, and she will need good painkillers and antibiotics. Also say I will apply principles of enhanced recovery program. Okay.
Mm.
So that is remove the drains and the things, the 4 points: high
Mm.
nutritional food, no prolonged NPO, early removal of the all tubes and ablation like that. Okay, all of these things to optimize the outcome. These are the things. And
Okay.
afterwards, patient can develop voiding dysfunction. She can develop the infection. She can have bleeding. She can have discharge, and she will have to stay home. She will be off work for some time, and then in the end her condition may not recover, may not be as much optimized as she would like to, and then she can have the recurrence of the symptoms with the next pregnancy also like that. So go over the operations: hysteroplexy,
Inshallah.
calculopexy,
Okay. طيب.
transport procedure like that. Okay, all of these things. So now I think the three stations are left, but it is late, so can
Mm.
we give you the homework? Because
Okay,
some of
please.
them are like
Mm.
some of let me see that what are these stations. Okay, 9.5. Yeah, fistula, they are always going to ask you.
Mm.
Remember, the most common cause of vesicovaginal fistula would be obstructed labor.
I'm such courses. Yes. Okay.
And in the older women, the cause will be post-surgical patients like that. Okay, that is
Mm.
one thing. Or radiation therapy also. The cancer patient can be there. Then there is this one. Okay, she has developed a post-hysterectomy wall prolapse. Okay,
Mm.
so these are about the fistula and this, but we also need to do the postpartum voiding dysfunction. That is also part of the same thing like that. Okay, then the Fowler syndrome, like patient is retaining the urine and she's not passing through. So two sessions on that also. So before we start the next session, um, these three stations: postpartum voiding dysfunction, we are going to I will ask you a couple of stations from here, give you a couple of stations from here, and then we will go to the next topic like that,
Okay.
which is going
Sitora,
to
I
be,
didn't get. I didn't get it. You said foul syndrome something. Foul.
yeah, Fowler syndrome. So what can you tell me
Fowler
about the
syndrome.
Fowler syndrome?
I don't know it. I don't know. It's the first time hearing about it. Fowler syndrome.